So welcome everyone. We're just letting everyone populate as we begin. We're so glad that you're joining us this morning for this town hall. And I'm just going to give a moment so people can find themselves here. This is a webinar format, so as you're joining us, you'll be able to see the panelists, but no one else. So thank you all for coming. We're glad that you joined us for this town hall meeting. If you heard the announcement during worship this morning, I had what is known in some areas as a Freudian slip. I said that we were going to have a town hall meeting not on racial inequity, but on racial iniquity. And I think that might tell you something about how I've been thinking lately about all that we're facing and the great need that we have for justice to roll down like mighty waters. So I'm very grateful that you're with us today for this conversation. I want to thank all of our presenters, and I'm going to quickly announce them or introduce them to you. And then we're going to start a conversation that'll just be kind of a far-ranging conversation between our guests. There is an opportunity, if you have a question that you'd like to submit, you can do that in the Q&A portion or the chat, either one, and get your question to us. And we will have some time at the end of the hour for those questions. So I hope that you will certainly take advantage of that if you have a question. So I welcome, as members of our congregation and of our discussion today, our town hall, Dr. Kwesi Manu, who is a general wound care consultant and the founder of Afro Wound Care and serves in the greater Philadelphia area. Deepa Willoughby is a licensed clinical social worker and is serving as a psychotherapist in the virtual health system. And Megan Craven is a pediatric endocrinology fellow in the Division of Endocrinology and Diabetes at Children's Hospital. Dr. Craven is also pursuing a master's in public health there at HUP. So we welcome you all and thank you for being part of this important discussion. So I will begin by saying that all of us have, over the last 14 months, read and heard and seen reporting on TV, on the internet, about the disparity in medical care for people of color, especially in the African-American community. And I was hoping that perhaps each of you could speak to something about the work you're doing and perhaps your experience of that, and we would start there. So I think we just, whoever wants to be first.
Okay, I can tell about my work I do and how the impact. So like Reverend Faulkner said, I'm a general surgeon by training, but over the past almost 11 years, strictly focused on wound care. And I serve in the Philadelphia greater area. So I go to a lot of nursing homes. So you can imagine the different type of nursing homes inside the city, outside the city, in the suburbs, and also along the lines of Doylestown, Quakertown, like almost kind of rural Pennsylvania. So I've had the privilege of taking care of people or residents from different socioeconomic backgrounds and even racial, diversity. And I can assure you that you could tell a vast difference in the, let me start even from the building, right from outside the building into the building, the standard of care, and it's also a reflection on the socioeconomic status. It's a reflection of that. It also reflects on the insurance status, and it also affects the quality of care in that building, and also affects the kind of employees you have in the building too. So I've seen it all firsthand, work with each building, hand in hand with each one. And I'm very familiar with the sentiments that these workers or residents express, because they always feel like the doctor have answers for everything. So they feel comfortable just telling you everything. So from there, I can tell you that, if you look at the inner city nursing homes, especially where most of the residents are African Americans or minority, I can tell you majority of them, the standard of care, the quality of care, um, raise an eyebrow. Let me put it that way. And as we go on, I will try and bring how COVID kind of opens up, like it's like a band-aid that you rip off and now you can actually see the manifestation of that. COVID just exposed it more in that sense. So as we go along, I will share stories in that sense.
Thanks, Kwesi. So Deeple or Megan, is there somewhere you would like to start with just your experience of, I mean, I know it's been incredibly challenging for all three of you these last 14 months, I'm sure of that.
I can share my experience. I work primarily providing mental health services to patients in family care. And my offices are in a couple of different areas. So I see patients living in very different socioeconomic classes and backgrounds based on which office they are coming from. And what I've noticed is there is a greater distrust, unfortunately, from my clients that are of minority or non-white demographics. So just being uncertain about getting vaccinated, having a lot of questions, struggling with more financial issues, struggling more with medical conditions, facing challenges of having to decide, do I go to the doctor? Do I put food on the table? Do I take time off of work? Can I afford to take time off of work? So these are challenges that, especially over the last year, are more and more of an issue. You know, it's not an option to leave work to take care of your kids who are homeschooling. It's not an option to not go in, even if you're not well, because you have to provide. So, and these are things that are coming up more. I do have some clients that work as caregivers who either in nursing homes or as, you know, private home health aides that have become ill. And I do have, you know, some of those clients are from Africa and living and working here, and some are Black Americans who have, you know, again, families that they need to support, that it's not an option to, well, I have to be here with my kids or I have to work, you know, it's both. So these are things that I'm seeing over and over again. And then mental health wise, just the amount of stress that comes up, the amount of physical pain, manifestations and complaints that come up look very different depending on the population you're treating.
Thanks, Deeple. And Megan, what about in your context in Philadelphia?
Yeah, so I'm, you know, I did a lot of inpatient service up until June, and then starting in July, I've been mainly doing outpatient. But I'm in West Philadelphia at the main kind of office there. And I think a lot of the things I've seen, you know, initially we converted a lot to telehealth. And so one of the things I've thought about a lot is access to care. And some of the barriers that especially some of the communities of color and people of color have faced as far as being able to even have access to telehealth. You know, you have to have a smartphone, you have to have, you know, either internet access or data. You have to have the time, like Deepa was saying, you know, many of them are essential workers and they're working in jobs during normal office hours. So a lot of issues with access to care. And then once it converted to in-person, we've gone back to a good amount of in-person visits, or some of our things require in-person visits. Transportation. Some of my patients have to take 2 buses in or the subway, and kind of that risk. And, they have to make that decision for their family and for their kids. Am I going to take this risk of taking transportation when there's an ongoing pandemic? So I think a lot of the social determinants of health and, those barriers that Deepal and Kwesi were speaking to have really kind of come to the forefront. And it's made me think a lot about access to care.
So just to make one very point clear, right? COVID did not create the big socioeconomic divide or so. This has been there. But what COVID has done is to expose it, show you things that we talked about, and it shows you the challenges that people, due to systemic racism, challenges that are there now is being exposed. And unfortunately, COVID just didn't come and spend 1 or 2 months. It's still there. So now you've seen the effect in a long, like if it was just 1, 2 months, we could have easily forgotten about it and then moved on. But COVID, as we speak, and it's been over a year, and COVID is still around. So we've seen it, and now we can talk more about it. And from what my colleagues are saying, I'll give you a good example. And this is not like, let me give you the general structure of how nursing homes are. The administrative role of nursing home, most of the time, the director of nursing, the administrator, what you deem as the white collar profession part of it, is mostly Caucasian stuff. And then when you come to the LPNs, the CNAs, the housekeepers, most of them tend to be minority background. And during the time of COVID, when that happened, where people were required to stay home, it was easy for the administrator and the people in the corporate office to work from home. So they were less exposed to, possible, exposure to COVID. Unfortunately, the CNA, the LPNs, the housekeeper, they can only, quote unquote, out of fear, take off so much, because at some point they have to put food on the table, take care of their family. So even if they call out 1 day or 2, you can only go on for so long. But the person in the office have that luxury of working from home, making calls from home, and yet they are the one in the forefront. And so they felt like they were abandoned, like nobody really cares. And if you recall, during the very first 3 months, there was issues with the PPE supplies. And it's true, as a physician that I do wound care, I know it has to be 1 gown per patient. I myself was at risk because I knew that that's the right thing to do, but it wasn't enough. So by the time I go through 5 patients, I wouldn't have enough PPE to wear for the remaining patient. So we had to come up with plans how to zone. So it becomes a zone where you can wear 1 PPE for those in that zone. Not the best, but better than nothing. So constantly being exposed. So that's why it was very hard to deal with COVID in the nursing homes in the first place. And guess who are the people working in those areas? You're having mostly people minorities. And when people are sick initially, they're afraid to go off because they want to put food on the table, unless they got really sick before. And testing wasn't good at that time. So they can fudge like, oh, I'm not, it's just a cold. It's just something like that. So that was one of the reasons why you could see the effect on the people, people, and there was a distrust. They felt like corporate management didn't care about them. As long as they're seeing patient and the bottom line, they make their money, they didn't care about them. That's what some people actually conveyed to me. Sorry.
Yeah, I agree. I think I saw a lot of that as well. It's true. I think not just, I know you're working in a specific area, but I think not just in that area, but nursing homes, even in some of the more affluent areas, the majority of the staff that is doing the direct care are people of color. And They are, you know, financially compensated less. They are often, you know, living in one-parent households. They are, you know, men or women that need to be able to provide for their families. They cannot take the time off. They were the ones that were becoming ill in the beginning. I had someone specifically that I was working with related to anxiety who had become exposed. She was a certified nursing assistant in the nursing, you know, in a skilled facility in a very affluent area, actually, in one of our most affluent areas in this area, where she was going in, doing her work, very reliable, and unfortunately, you know, contracted the virus, became ill, fortunately did recover, but subsequently was struggling with severe panic attacks. So much so that, you know, she would leave work and then go directly to the emergency room, suspecting she was having a heart attack or having some other cardiac issues, maybe related to her COVID. You know, her, even though she had recovered, she had heard all these stories and had been reading things, and so, you know, had subsequently become extremely panicked. And unfortunately, I think in the frustration of her repeatedly returning, I think staff in the hospital were getting a bit frustrated with her too. So now, you know, she's gotten sick. She's had issues where she's been out of work. Financially, she's struggling, which actually destabilized her housing situation. And now she's going to the hospital to seek help and being looked at like, you're a problem. Why do you keep coming back here? And, you know, further escalating the cycle of emotional distress for her. So these are situations that were coming up more and more as, you know, we progressed through the pandemic, and then, you know, all of the incidents that have occurred, not just in the last year, but over time, that, you know, we've kind of reached this point.
Just to add to that, I'll tell you one story. So there was a CNA, actually, it was a CNA and an LP and a nurse, and they got sick with COVID. They had to be off for almost 2 weeks. Like, I think they were exposed. And during that time, you had to be quarantined for 2 weeks. They felt well, but what was happening was they weren't being compensated for that. So there was that constant fight because it's not my fault that I'm exposed. I came to take care of your residents. You're getting paid for that. So how come if you want me to stay home for 2 weeks, then who's going to take care of me? Who's paying for me? So there was a fight. There was like there's animosity between the people working at the corporate level, because people at the corporate level have a lot of sick time off or built in, you know, have privileges in terms of working from outside or time off. That way, they don't have that. So you could see the frustration being vented. So coming to work, as much as they want to put food on the table, frankly, they weren't coming there with a smiling face. They just think like it's something I need to do to survive. So they come out there. So it actually did affect their work too, because not everybody was doing it with such love. And I know some of these people, they're very loving people in general, but when you talk to them, you get a true sense that I'm only here because if I don't show up and I don't make X money, even in, and they had to, because of that, they had to kind of lie about their symptoms or exposure just so that they can be there to work. And that's what also kept perpetuating the, you know, infection of COVID, because, you know, they have to take care of their family. And corporate didn't, you know, wasn't also looking out for them. And I know COVID started with a bang. Nobody expected it, but you could see right away those who were able to stay away from it, and those who had no choice had to have to keep going.
And I think what you said earlier, Kwesi, is, you know, important. Like, this just brought out issues that were already there. Like, it just made them more prominent. Like, I think you know, those issues were already, like, a lot of the issues were already kind of in place. It's just that when COVID came, as you said, kind of with a bang, like, all of a sudden it became very apparent.
Right? There's no ability for the person who's working paycheck to paycheck to sustain themselves, whereas the person in a corporate position has the savings or the funds or just in general, the income, the salary, that supports the ability to, if I'm not in, it's okay, versus I don't have the option to not go in. I have to be there because if I don't go in, then I can't pay my bills. I can't pay for food, can't pay for my health care. I don't, have any coverage or benefits unless I'm there.
So, yeah.
So it's not the same context, but I grew up in Appalachia in the 60s and 70s, and certainly had friends and acquaintances that struggled with true poverty. And I think this, as has been mentioned a couple of times now, this dovetailing of the socioeconomic and medical and race, there's so many layers of the crisis. And as you said, it's not something new. It's kind of pulled the, how did you say, Kwesi? He's pulled the bandage off the wound that is there and real. And there's so much going on that needs to be addressed. And I think that what often happens, I'll just speak as a white Christian and pastor of a church, what often happens, it seems overwhelming and not knowing how to respond. And so we need to find ways, it seems to me, in the church where we respond systemically, trying to help in the larger questions, but also responding on a much more local, trying to work for change in a very grassroots kind of way. But I appreciate the conversation because it is very complex. And I think that sometimes what happens is that Americans like things, simplified. They like them, no pun intended, to be black or white. And the complexity is hard for us. It's hard for me, I'll say it that way. And y'all are raising that there are really complex things going on that are impacting people negatively every day.
Right. And to take on the question, I see a question from Joseph.
Mhm.
Asking if healthcare is an infrastructure issue, and if so, how much should the federal government be involved? I don't know if I should say it's an infrastructure issue, but it is a big issue. And like Reverend was saying, it's a very complex issue. Most of the time when we think about healthcare, people think it's just direct patient care, but there are different facets to healthcare. And I think both Deepa and Megan will, tell you, as you dive deep into healthcare, it's like a network of caves. You just, as you touch on one, you open another door, you touch another level that you have to deal with. And I think as much as it's complex, there can be some kind of framework that can be made on the federal level, federal level, that from there each state or each entity can take, and it's like building a tree. Let's say you put up a tree with big branches, and then from there, I think states, counties, you name it, local governments can also add a bit more branches to it also. So our healthcare system is just all over the map. That is one thing. And when you add the concept that most of these healthcare systems, or whether the pharmaceutical companies or the buildings, whether the hospitals or nursing home, most of them are for profits. Um, you could see where the challenges come, because at the end of the day, it becomes the bottom line. It's money. That's what becomes. And when you talking about money, people find ways, for lack of better expression, to cut corners. Let me give you an example. For instance, in the nursing home, I don't know exactly how the regulation is. You're supposed to have a ratio of a nurse to residents, and they've made it so lax. And this is all due to lobbying from companies that represent the nursing homes or personal care buildings. So if I say one nurse to 10 residents, but you can also go one nurse to 20, why would I do one nurse per 10? I'll push it to the limit, one nurse to 20, or one CNA to, let's say 15 residents. And you can, the ranges, it can be 1 to 30. Why would I hire two nurses for 30 when I can do one, if that's what you're telling me, right? But these are difficult jobs. And guess what? The ones doing those difficult jobs, and they are going the most difficult ratio, 1:30, or 1:10 for the nurse. So it makes it very hard. So yes, I think from the federal level, there's a role for them to look at it and actually make some concrete changes or some basic framework for us to work with. And it all comes to people trying to work on a goodwill. It's because if you look at money, if money comes in, you will not be able to make those changes. But at one point, we need to take a step aside and think about, these are human beings we're dealing with. Let's do what is right for human beings, for people, and then let's see how we can add other things to it.
Yeah, to add to that, I think, what many people don't know until they get to that point is, the cost of nursing home care is astronomical. I mean, most nursing homes, you're talking a $10,000 a month, to live there. And the reality is most of us, even in a good situation, can't afford $10,000 a month. So the funding comes from where? Mostly the Medicaid programs. Medicaid is a federal program. That's the only program that actually affords to pay for someone to live in a nursing facility. Medicare does not, which is something, like I said, again, many of us do not know and don't find out unless you're either working in the field or, you end up with a loved one in that situation. And this, becomes a challenge. So when you're looking at programs like Medicaid that are paying for care, the agencies, what I have noticed historically is the agencies that are hiring workers and paying them lower because it's all Medicaid funding. And so, the people that end up taking these positions, unfortunately, then also get shortchanged. And the majority of them tend to be in that minority race, that's coming in to take the position. They're getting paid less, and you just kind of perpetuate this ugly cycle. Then they just don't pay as well, and they are the caretakers. They're the ones coming in and doing the work and putting in all the effort and feeding and bathing and washing and taking care of our loved ones, and yet they are being compensated the least.
And somebody would say, why should we care? Think about it. We should care because if they're the one going up, they don't feel the need to, or they're not built in system to protect them or to improve them. They'll be the one going back and taking care of our loved ones. And if they're exposed to more COVID, then COVID is not going away anytime soon. So it's almost like a vicious cycle. Somebody like, okay, somebody has to do the CNA job, which I agree. Somebody has to do it. But we're telling you, these are the people that, due to certain systemic issues, they find themselves there. I'm not saying there's a solution to solve it right away, but I need you to see it so that as a society, we're moving forward, we can address these things. Because I think anybody, it doesn't matter race, if you should have that job, it should be well compensated or certain things built in to protect you so that it doesn't matter who it is. But if, as the current situation, if it goes on, then we may not be able to get rid of COVID anytime soon, because people will feel the need to go to work when they are sick and then they pass it on. Because I keep saying, the residents in the nursing home, none of them, 90% ever went out when COVID came. They were mostly in the nursing home, but somehow they got it and it spread like wildfire. So who was bringing it is the people who are coming from home to them. When COVID happened, the first couple of months, most nurses, most doctors and nurse practitioners, the first month or two, most of them did not go to the nursing home. Like Megan was saying, we tried to do telehealth at that time. The idea was to minimize exposure. But these CNAs you can't do telehealth with patient direct care or resident direct care. You have to be hands-on to do that. The LPN, the nurse, can't do telehealth. They have to be right there with the patient. So something to, for you to get the big picture, to have an understanding why it's such an important issue.
Well,
I think somebody's
could I
asking.
then,
I was just looking at
Go
a
ahead, go ahead,
question.
Deepa.
Yeah, sorry. I saw there was a question about, the vaccine and hesitancy about and availability. Certainly, here this kind of ties back into what Megan was saying earlier about having access to sign up. In some regards, being able to get the vaccine has been working very well in New Jersey, and in other regards, not so much, because if you have the internet and you can log on and you can sign up with the state registry, wonderful. You can most of this area. So I'm talking Burlington County, Camden County, where Gloucester County, we're doing great. You can log on, you can sign up for, where's my local site, somebody reaches out, you get scheduled, you get in. However, if you belong in that socioeconomic class that doesn't have access, unfortunately, to the internet, or have the know-how, the skill set to log in, and to be quite honest, I think this is something that's been a challenge for everyone, this last year. Just think about how much you've had to learn to do online, right? So we're talking about people who are maybe older, who have limited education, who have limited financial resources, who don't have internet, who don't have laptops or computers or, some smartphone to sign up for the vaccine. These are the challenges that we see in the African American, the Black American community, in other minority races, populations that don't have access, with regard to being able to get it. Otherwise, from my experience, it's available. It's certainly not that it's not available here in New Jersey. Certainly, I have heard stories, I think, depending on in other regions where people are waiting in very long lines, waiting outside, it's freezing cold. Even a little bit of that happened around here in the beginning. I think that has significantly improved. And again, I'm only referring to probably these three counties, Burlington, Camden, and Gloucester. So there has been improvement with regards to that. But that's for those who were able to access those, computers or cell phones or whatever, tablets, to sign on and had the know-how, or had somebody who was able to do it for them. As far as the hesitancy about getting the vaccine, that's a whole nother issue, which unfortunately, I'm seeing quite a lot of. That has really plagued my patients in particular, emotionally, mental health wise. There is a lot of distrust. There is a lot of feeling like their questions are not being answered. There is obviously the history and the past of, purposeful harm done to this community, in experimentation, referencing back to Tuskegee. There is a lot of distrust. There's a lot of confusion. There's a lot of, if I do this, I'm the only person here to take care of my kids, my mother, my father, my whoever. And if something happens to me, what happens to them? I'm not sure if anyone has something else to add to that.
Yeah, I would say, I always say it's appropriate mistrust, right? Like a lot of these communities don't trust us because of our history. And so I think it's a really understanding that. And then I think making sure that there is like proper access, in Philadelphia, there's a group that has been talked a lot about in my public health classes, the Black Doctors COVID-19 Consortium. And that group is focused on giving access by partnering with trusted people in the community. So they actually have partnered with a lot of the churches in like the Philadelphia area, the Black churches, and really kind of working with them so that it's coming from a source that is trusted as opposed to coming from someone like me. And they've also worked on access as far as not making it required that you have an appointment or having actual sites in the area. And they did this first with kind of COVID testing and then have now done it with the vaccine. And I think there's a lot of factors we have to consider with that and make sure kind of it's being done, that we're giving access kind of in a way that will be well received.
So let me share a few short stories, and this is family and close friends regarding vaccine. So for my background, I'm actually a naturalized American, so I won't say I'm a first generation American. I have extended family. Most of them are naturalized American or green card holders. And for that extended family, if we should all meet, you will see a spectrum of varying socioeconomic background. I have cousins who are working in Wall Street, big, Fortune 5 companies. And I have cousins who are CNAs in New York and stuff. So I've seen the spectrum where the exposure, the economic privilege in my extended family. And yet I've had calls from the different sectors. As a little bit over a month ago, my cousin who's a CNA calls and she wants to hear from me direct. And her question is, they are giving it in my hospital. Should I take it? All she wants to know is her cousin, who's a doctor, trust. So that means if I've taken it and I've said I'm okay, then it doesn't matter what else anybody has said or read. And she has her hesitation. But as soon as I told her, you'll be fine, take it. I haven't grown a horn yet. And then I told her that, look, I don't know the long term. If anybody says they know the long term consequences, that's a lie. But I can tell you the immediate term, it helps and stuff. We're going through that. It was a 2 minute conversation. She put the phone down. She had it. She called me later that night, told me she's got it. I have a cousin in Texas. He works, well-to-do guy. He calls me, Doc, what do you think about the vaccine? Should I get it? And then we spoke for about 5 minutes. It's like, okay, since you say so, I'll get it. I have a nurse who's been a nurse for African American. She's been a nurse for like 11 years. She's actually working on being a nurse practitioner now. I saw her this Friday and she still hasn't got the vaccine. And when I spoke to her, she's like, Doc, and this is somebody who is a nurse practitioner that's been in the system. And she has hesitation because of what Megan and Deepo said, the history of the country in terms of healthcare, what is done to the African American. She's been in it. She sort of has a sense of it and she has her own hesitation. So that is one of the reasons why initially, and I think it's improving now, why there's been such a big hesitation with the African American or minority society getting the vaccine. And obviously, people really tell some very good stories about the vaccine. And some of them, when you hear it, you just shake your head. It's like, I don't even know what to say to rebut that. Another thing I'll tell you is I have patients in the Chester area close to Commodore Barry Bridge. So I do home visits too. And they kind of lament how they feel like they're not doing enough to bring the vaccine to them. And they complain to me like, look at the other township, because if you drive 10 miles from that area, you're in a more affluent, township right close to that area. And they are getting the vaccine and I know last week the gentleman had his, but a month or two ago, he's lamenting nobody has reached out. He can't go out because he's taking care of the sister. Once again, all these things come in. And so access, bringing it to them, they feel like they've been neglected. They're always at the the short end of the stick, the tail end. Nobody cares about them. It always goes to the affluent place, but they're the one that needs it because they are the one who also have to go out and take care of people, or they are more exposed in that sense. So so that is the issue with, to some degree, with the vaccines. So they need people that they can trust. And sometimes we also have to be honest, in terms of what the vaccine can do in terms of short term and long term, but that's.
Yeah, I am. So we actually at my hospital system actually have a African American CEO. He's been in place now for several years, so prior to the pandemic starting, but has really, been working to make an effort to make sure that the community feels like they can trust. So making sure that we are sharing those stories online and in platforms such as like Instagram or Facebook, or just media posts. And one of the things this month, the focus is really on prioritizing minority health, so that they feel comfortable, that they feel like they're being heard, so that they feel like they can ask questions and have them answered. And encouraging this by reaching out to our patients who have been vaccinated, or our patients who have, sought medical attention for any condition that they may be dealing with, or just for routine checkups, to be quite honest, because the community itself has a tendency to not, to skip those things, to skip their annual visits, their annual blood work and exams, and get checkups. So again, going back to, I'm busy, I gotta work, I got this, I've got that. And, I'm not sure I believe what that person is gonna tell me anyway.
Just to add, Levy, to pharmaceutical companies to have over the years, in the name of profit, also have done some not so good to the minority community. For instance, Pfizer, the name Pfizer, you don't go to Nigeria and mention Pfizer, they will walk you out. Because I think years ago they pushed some medication that was fake, and there was death that happened. So you can imagine, if Pfizer has Moderna, do not take Moderna to Nigeria. And these information will infiltrate in other African countries. And then when you have people of minority, like I said, naturalized Americans or green card, they are most of the people who are working in these nursing homes or in the healthcare system in that level. So they know about the stories that happen back home in their countries in Africa. And now they have more people who are propagating what happened. So there's the mistrust or distrust in these pharmaceutical companies. So if Pfizer has medication out there, what makes you think they will now care about us if in the past they did something to harm us? So these would tell you the history, the history and the experience of the people also play a role. And it may have happened halfway around the world, but it's here.
And if I may at that point, we received a question from someone. It's a longer question. I'd like to read it for us, if that's okay. As a healthcare worker and an ordained minister, I appreciate all of the valid anecdotal evidence that has been faithfully presented today. I also assert that systemic racism is at least in part a failure of faith and the deep divide that exists in Christianity in our country. Evangelical Christianity and the silence of our mainline brothers and sisters has helped create the political divide that stands in the way of our getting to the policy solutions that will help with many of these valid concerns. What are we as faithful Christians doing to bridge the divide in our own faith community?
Well, I will start by saying, Reverend, if you remember, a few months ago, you gave a sermon and I sent you a text, right? I did text you and I told you, well, that I know it wasn't easy. I mean, you told me how it took you time to work on that. And I felt like it was something that we needed to hear or needed to come from the pulpit. And I agree with the overall statement or question. silence has played a role. And I think it's about time the church has to speak up and speak well, and not speak just for a week or two. I think it's about time that every now and then we should have sermons about, and I tell people, what would Christ do? I always, when people argue about stuff, I always say that the simple question is, ask yourself, what would Christ do if this is going on? And if you deep down in your heart, you know what Christ would do. So why don't we try and do that? So I agree that it's about time the church, and it's not just from the pulpit, but as a community, we need to, and it may require that we need to have a strategy, because we didn't get this far with the people who have, allowed racism to go on, just doing it out of the blues. They sat down and figured, what are the things we can do to create the system? So that means we also have to sit and come up with a plan. How are we going to fight the system, or able to, negate and mitigate some of the things that's going on? So, so yes, that's what I would say for now. So I want other panelists to talk.
Yeah, I think we're here to take care of each other, and I think, Kwesi, you said that before, why should we care? We should care because we're all here, in this together. So we have to, care about one another and take care of each other. And just kind of remembering that, we're not here alone. We were put together for a reason. And, to go back to that and remember to use that to move forward. And this is why we care. This is why we make that effort. This is why, to go out and preach and to encourage each other to care, to pay attention. It's kind of sad, I was thinking, that made me think of I keep seeing all the stories about the Asian community and the violence that's been going on. And I have just seen multiple stories in the last couple of days. One about the lady who was, kicked and punched like repeatedly outside of, I think it was a hotel or something. And the people just came and shut the door. It was like an apartment building, and they shut the door. And I'm like, how do you see that happening? And you just shut the door, like, oh, well, do that out there. Don't bring that in here. And then there was the other story about a woman who was on the train, and the person who stood up for her, she's having all these like horrible things, racial slurs and things spewed at her while she's riding this train in New York City. And all these people, like all these tons of people, nobody's saying anything. Like everyone's just like looking away, like they don't hear or don't see what's going on. And the person who actually said something was a homeless man. That was the person who actually intervened. And I was thinking, are we so lost that we got to the point where, if I'm not suffering, then I don't see it? It's just sad. But this is the thing, I don't know if it's just become a very selfishness or a very closed off mentality, but so important to take care of each other.
Yeah, I agree. And I think what I was going to say is my line of work takes me through different parts of Philadelphia greater area. So I'm exposed to, going to an affluent area or more Caucasian area or more minority area or so. And I found out that most of the time when I get to places, it doesn't matter which community, there's some kind of perception or expectation that they're looking for. And some people are surprised, oh, he's African American or he's Black. And some people are like, oh, are you, what I'm trying to say is, but what I found out that after I get to know them, you find out as an individual, most of the people are very good people. But collectively, I think that's where the society collectively, we've allowed a few to drive the agenda. And I think because we are comfortable, or maybe our situation haven't been harmed, we just stay there because we're okay with where we are. And then a certain segment of the population just drives that. Is it just purely economics, like, being, for the love of the money, or doing well, so you need to put somebody else down? So I think the church probably needs to go back to the root of like preaching and working on humanity, love for one another. We need to find maybe programs where we can move people from our comfort zone, and we need to encourage that, because it may be the church is doing that, maybe a small percentage is only doing that, but maybe we need majority of the church to be involved in that, instead of just maybe 20% or 30% of the church members. We need to get more people. We also need to get the younger folks, toddlers, kids, teenagers, also more exposed, or to be out there in terms of mingling with people from different economic and racial backgrounds. Because if you're not familiar with people, or comfortable with, and I don't know where the discomfort comes from, but if you're not familiar with people, there's always the sense of, oh, I'm here, they are there. So I think it's the church has a lot of work to do, and it's not a 1 or 2 year, but it has to be something the church have to look to undo centuries of work that has been done. So yeah.
And I think that our history, so, this is something that Robert Jones and Jomar Tisby and others have written so clearly about our history in America, about the entwining of racism and the Christian church, is part of our history, a sad, terrible part of our history. So I think part of my response to that question would be that we are trying to have conversations and trying to educate people so that we can think more deeply and more honestly about the situation, but also so that might empower us to work. So I do want to take this opportunity to say to our church family that we are eager for people to be involved in the larger work of education and mission, and trying to think of ways that we can, as a church family, respond. So that is part of our hope and the work that we have been about. Paul Lehman was a great ethicist of the last century, and he talked about humanization, that at the heart of the Christian faith was for humans to be truly what God created us to be. And to Deepal and Kwesi's points, it might be a great thing if the church began just to follow the simple, to do unto others as we would have done unto us, and begin putting that into play in real ways, in practical ways, not just, that sounds so sweet, let's put it on a card. That also calls for, hard, sustained, dedicated thinking, talking, action. And that's the hard work that is also part of what we need to be doing as a church, as our church, but also as the larger American church. And I'm grateful for all the places that's happening, but I would love for us to be part of that even more at Trinity. So I know that we only have a few more minutes. I think we have responded to the questions. Perhaps if each of you would like to say something as we bring the conversation to a close, maybe I'll turn first to you, Megan, and let you have the beginning of the closing words.
Yeah, I think thinking on that, in that kind of vein of the last question, I've been thinking about a lot about this over the past few years, and I think the biggest thing I've learned is to listen and understand other people's perspectives so that you can make a meaningful impact and kind of help in the ways you can individually. But I think more and more, I think going as a community and helping locally and trying to make an impact locally, I think I think there are a lot of things that could be done kind of on the, national level, but I think we as a church really could have an impact locally. And so I think kind of advocating for change in our own community is kind of the first place to start. And so kind of that's where I've been thinking about in the last kind of couple of years, and kind of as things have progressed, really just listening to perspectives and making that change on a local impact level.
Thanks, Megan.
Well, thank you all once again. So I'll say the story of COVID and racism, like we all said, it's and the effect of COVID on socioeconomic issue is nothing new. It's been there for generations, and just the COVID exposed it. But it's very important that we all care, because these very people, or the majority of workers in the healthcare system, who are doing direct patient care, are people from minority backgrounds. And if their situation is, or their condition or their plight is not improved, then as a society, it will still reflect on us. It will still affect us. And when you have a pandemic, COVID, which doesn't discriminate, doesn't matter your status, race, or your economic, socioeconomic status, if you get infected and you're not lucky because of various reasons, it can kill you. So you can think of your loved one either in the personal care, assisted living, or nursing home. If it's not you, think about your loved one you have around the world, and improving people's lives or taking care of them, maybe indirectly, maybe improving yours too. And also, it's the right thing to do. It's the human thing to do. I always tell people it takes less effort to be a happy person or a good person, and it takes more energy to be mean or mean spirit or be mean to people. So what I'm trying to say, it's a society, if we take care of people and we do right by people, I think we all benefit in the long run. So, but there's a lot of work to do. The church has a lot of work to do. Individually, we all have work to do. We should reach out. We should also give people benefit of the doubt. I know we are human beings, we are prejudiced. I am, I prejudge people, that kind of stuff. We should try and fight that, hold it down, and give people benefit of the doubt, knowing that most people are good people. People are good people. And once you get to know them, you find out that, oh my God, I should have known this person a whole lot earlier or so. So, yeah.
Yeah, I agree. I think, we have to remember somehow along the way, I guess, we've gotten lost and forgotten to love each other and care about each other. And everybody impacts everyone else. We're all in this relationship together. We take care of one another, we all do well. We don't take care of each other, we create all sorts of turmoil, economic distress, loss, more disparities. But if we, band together to look out for one another, because it's all relationship. The caretakers are the ones that are going to be there for who's, even if you are more affluent and you have the means, if the people who are, traditionally the caretakers are all ill or not doing well, doesn't matter how much money you have, who's going to take care of that loved one of yours? And it's important. It's important to care about one another. So, for so many reasons, to just be there to support one another, it matters.
And that is a fantastic note to end on. I would just highlight that loving others means also those who are not like us, and those who are in need of being loved and supported and helped. And we want to continue to be part of that work. I want to say thank you, Deepal, Megan, Kwesi, good sisters, good brother, for being part of this conversation. I want to thank you on my behalf and behalf of our congregation for the work that each of you does every day to care for people and to spread the love of God through your work as a medical care provider. So thank you. Thank you all for joining us. Our time has come to an end. We plan to continue to have these conversations. I hope you will join us. And if you would like to be part of that work more closely, you can certainly let me know, or one of the panelists, or the Mission and Outreach Committee, Eric Juarez, Linda Ween, and Jenny Stark. Thank you all. Let's go from this place to love and to work together. Thank you all.
Thank you.
You.